Good morning, everyone. This morning, we're joined by Emily Mendenhall, Provost's Distinguished Associate Professor in the Science, Technology, and International Affairs program at our School of Foreign Service. Professor Mendenhall is a medical anthropologist who has written extensively about the structural and societal forces of human health and disease. So, Emily, thank you for taking the time to be with us for this conversation. As a medical anthropologist, your work brings social and environmental challenges such as trauma, poverty, and social exclusion into focus with issues of global public health and medicine. Can you describe for us how you approach your scholarship across these intersections?
Yeah, there's a few different ways. I'm a medical anthropologist, but I also have a degree in public health. So I'm always thinking about kind of the squishy experiences and stories and the kind of more intimate, less visible experiences, as well as the more rational kind of responses that people want to use and see. So I start always with stories. So I've spent hours and hours around the world listening to people's stories. I've worked primarily with women, but definitely not exclusively. And I looked at kind of experiences of trauma and oppression and what those mean to people in their lives and how they tell that story and how it's reflected in mental and physical illness. So often I look through the prism of diabetes, type 2 diabetes, or HIV, breast cancer, and look at how that relates to depression or anxiety, but also how people talk about these experiences. But I look at these illnesses as reflections on different types of ways in which people talk about suffering and what that means. But I've also shifted to look a little bit more and focus more on flourishing. So, what does it mean to flourish? And what ways do people identify, define, or recognize what they need to flourish? And a lot of this work has been done. I worked for 5 years at Cook County Hospital in Chicago, but I spent a year in India. I've, for almost 10 years now, been working in, obviously not always there, but working as honorary faculty at the University of the Witwatersrand in Johannesburg, South Africa, and I've done some work in Kenya and Ethiopia. And this work is really meaningful in part because what I've found is that people experience extraordinary difficulty, gender-based violence, institutional violence, institutionalized racism, all sorts of things that happen. But how people experience and perceive and understand and cope with and become resilient through these kinds of experiences are really different. And so how people define illness differs from place to place, and that really matters because interventions in one place are not the same as they should be in another place. People need to define on their own terms what they need to do well. And of course, medicine isn't the only solution. There's so many ways in which people heal, including, for example, a lot of my work in South Africa focuses on prayer, or being together, or feeling heard, or feeling cared for. So these are just pretty important human experiences.
Sure. This past year, you conducted a study in your hometown of Dickinson County, Iowa, in the Iowa Great Lakes region of the Midwest, looking at the perceptions of public health and public health safety measures in response to COVID-19. You've shared your findings in a paper released earlier this month, and you're currently working on a book that expands on these insights. Can you share some of your findings with us and some of the ideas that you are exploring?
Yeah, when Georgetown shut down, we all went virtual and we taught our students with, so much dedication and care, and still are virtual. During the summer, and I have two little kids. One just turned 5 and one 7 last summer. So they were 4 and 6 during the pandemic. So we were juggling all of these things and pretty exhausted by June. So we got in our car and we drove 20 hours straight. We even made our kids stop to go to the bathroom on the side of the road because we're like, we're going to get there. There was a lot of unknown at that point. So we drove all the way where my sister lives next door to my parents. So we were able to kind of quarantine, and we distanced from my parents to protect them, but we quarantined with them. And when I got there, it was pretty shocking because here and in my, in a community at Georgetown, we were really taking things seriously. we were wearing masks, we were socially distancing, we shut down our way of life to really protect each other and care for one another. And then when I got to Northwest Iowa, this place that, really cultivated me, I always kind of conceptualized was this close-knit community. No one was taking the virus seriously, and no one was wearing masks, and all the restaurants were open, and some were kind of socially distancing. One restaurant shut down, but everyone else was just kind of going forward like it was any other summer. And I was just shocked. But along the way as well, my brother-in-law was leading the COVID-19 response. So my father was a part of the city council. So I was embedded in this kind of political and social and medical response that was being undermined in such a deep way. And so we wrote this piece looking at how people look and think about coronavirus. I actually wrote the piece. My husband led it. It's on framing, and so it was actually a very collaborative piece. The senior author is my brother-in-law. We kind of came together to talk about what we saw, which was very fun. I work with people all over the world, and then I have this one family paper, which is interesting. But it was really interesting because we found that there are people who are perceiving coronavirus like a crisis, and they're thinking about this kind of global vision, taking science very seriously, masking. This is largely the Georgetown community, but we found these other real kind of different deviances of perception and experience. So there's the business community that is really worried about surviving, and they're thinking about it in terms of, we called it constraint, right? And then there's another frame looking at concern. So people are really concerned about their family and their loved ones, and they're not maybe totally sure about these kind of broader things that are happening, but they're very concerned in protecting one another. Maybe not thinking about it as this global crisis, but thinking about it as a community level. And then there's the conspiracy frame, which we've seen and has been written about a lot, where people think it's a hoax. But there's also this kind of dimension of vaccine hesitancy or disbelief. There's this really interesting piece I read the other week that looked at how anti-maskers and anti-vaxxers are very much aligned. And this isn't just one political group or one religious group. There's this kind of this collective resistance that's embedded in this other cultural dimension that I'm trying to really get at and thinking through as I'm writing right now. But this kind of collective deviance or notion of truth is something that people are using to undermine individual responsibility or personal responsibility, which is very interesting. I'm trying to get at, because there are these incredible pockets of resistance where there are these global forces where people are really coming together and demonstrating things we never thought the world could do, which maybe we can foster all of this energy for climate or other crises we face. But there are these pockets of resistance where people are collectively creating kind of cultural resistance to this individual personal responsibility of caring for one another. So the book comes to together at the center of what it means to care for each other. So that's kind of what I've been digging through, and it's been this extraordinary kind of reflection on pockets in the United States and what we do as global leaders. So
thank you. I really look forward to reading the book when it's released. Now, you mentioned a moment ago your work around diabetes, and you've helped to deepen our understanding of disease and illness and the social determinants of health. And can you talk a little bit about some of your work in this area? In 2019, you published Rethinking Diabetes: Entanglements with Trauma, Poverty, and HIV, with insights on the prevalence of diabetes through the lived experiences and the lives of women impacted by the disease around the world. What aspects of your insights in this book do you consider most resonant today, and with what you've just described in your current project?
Yeah, there's two kind of pieces to my diabetes work. So I've been asking, in one way, I've been asking people through diabetes to talk about trauma and social stress and how stress and trauma become embodied. Because one of the critiques of work on diabetes is, within kind of prisms of public health and medicine, there is so much blaming for people who have metabolic disorders, hypertension, diabetes, obesity. And this is kind of embodied to, you're not eating right, you're not exercising enough. And, the prescriptions are diet, exercise, and medication. But what we know is that there are structural issues. There are these broader forces of neoliberalism and kind of the expanding and flexibility of the lives and lack of security that people are holding in their lives that have created different systems of living, right? And different ways of surviving around the world. There's these really interesting kind of ways to think about, not on the one hand, you can look at what foods we're eating, how they're packaged, and the limitations on corporate responsibility for what people are promoting to who. It's kind of looking at the kind of historical work on tobacco. Regulating tobacco in the United States was one of the greatest public health successes. Well, where did tobacco companies go? They went to low and middle income countries, and they really tried to pander to clients in low and middle income countries or lower income people, right? This is what they did. And then they bought into big food. So there's this whole aspect of corporate responsibility around who eats what and why and who's targeting what. So it comes down to these ideas of food deserts. Where are McDonald's located in the United States? Where are nicer grocers located, or affordable grocers? And this is a structural issue, right? So when we get to the questions of what's causing diabetes, we know that there are these broader structural dimensions. And so some of this work around trauma and what is diabetes and how it's experienced is challenging these notions that it's individual's fault. Because when you think it's your fault, it makes it even more difficult to think about caring for yourself and others. So how do we care for one another? So that's one of the questions of what is diabetes. And it's also challenging this notion that type 2 diabetes is a panacea. Because there's a number of clinical pieces that have come to say that, diabetes, type 2 diabetes is actually multifaceted, and there's all these really complicated psychophysiological links to it. But what I look at through stories and through linking this work on how people experience and embody the condition, you can see how strongly linked stress and cortisol and untreated anxiety and depression become in these experiences of hypoglycemia. So it's important to kind of unpack this part. And so really thinking about how trauma and chronic hunger and uncertainty, and my work in Ethiopia really gets to this with Professor Lauren Carruth at AU, is looking at how chronic displacement and hunger and conflict and lack of healthcare can produce a type of type 2 diabetes that's very different than we see in the United States. And understanding the psychophysiology of those conditions are crucial. So that's one part of it. And the other is I led a series of papers in The Lancet, a medical journal out of the UK, on this concept called syndemics. Syndemics are, in one way, they're a force of changing how we think about illness. Epidemics think about how diseases move through a population. Syndemics, like epidemics, look at how diseases move through a population, but they're also taking into consideration how diseases never move alone. I've actually interviewed hundreds of people around the world, and I've never met anyone with one problem. People always experiences conditions that are clustered and interactive, and those conditions and interactions need to be taken seriously. So I give these 3 rules for syndemics that are kind of easy to understand. The first is that 2 or more conditions cluster within a population. The other is that there is this interaction that fundamentally undermines illness and adverse health effects. Those could be biological, those could be psychological, linked to mental health, could be linked to eating because of stress, could be linked to stigma, like a social dimension. And then there's this other third factor that inherently makes it syndemic, is that it's driven by larger political, economic, ecological factors. For example, as we see climate change, this is a typical STIA question or STIA problem. As we see climate change in the highlands of Malawi, mosquitoes are living in higher altitudes. So people with HIV who may not have faced malaria, for example, are now having a new co-condition that they're experiencing with a chronic illness that has been long managed. But now with this new co-condition in this new community, people are trying to deal with it in a different way. So that's an example of how a syndemic could emerge. Also, syndemics are, especially in the United States, are very, very strongly linked to systemic racism and medical racism and poor access to healthcare. But also it's hard to deny the history of enslavement and segregation in the United States that has produced such extraordinary inequality. And in many Black and brown communities in the US, we see clusters of conditions. If you look at any map of diabetes, you see the highest rates of diabetes on Native American reservations. That's not by chance, of course. And we're seeing a similar thing with COVID. So COVID-19 is also obviously increased risk for people with non-communicable diseases like diabetes, heart disease, um, hypertension, and these conditions are creating extraordinary crises. Especially I read one piece about how the Navajo elders have died at such extraordinary rates that the families are in such extraordinary crisis. And so thinking about how unevenly COVID has moved throughout our society is just a reflection of our historic inequities that have been fueled and fostered over such a long period of time. And that's why it's interesting to see how America responds in times of crisis. Do we care for each other? Do we collectively care for who we are and those people we don't know, those people we care for? Our individual behaviors and collective allegiance to caring for one another is critical right now. And it's why I'm so interested in this other project as well, because really caring for one another is what brings us together, right? In a global community, as a nation, and also at Georgetown. It's something, these are real conversations my students have every single day. How do we care for each other?
Sure. For those who are hearing the terms syndemic for the first time, how would you compare and contrast the word syndemic with pandemic as we apply it to COVID-19? How would you we want this may be an opportunity for us to get our vocabulary right
Yeah.
in terms of how we talk about COVID.
So you've been following my work a little bit, maybe. So syndemic is very much like epidemic. A syndemic has historical roots. You know, anthropologists argue that context matters. That's basically our bread and butter. We study people, but people have histories, right? Nothing is cross-sectional. You can't understand anyone from just one moment in time. Every person, every community, every nation, every society has a history. And really understanding that history when you're thinking about disease matters. So syndemics are historically contextual. So I think a really good example, so Richard Horton from The Lancet, who shepherded our series on syndemics in 2017, has also been shepherding kind of conversations about global syndemics, which I think is just such a misunderstanding of the term. So I've written a couple correspondences in The Lancet with him about how this idea of a global syndemic is misguided because it erases these histories that are foundational for understanding what syndemics are. For example, if we erase medical racism from vaccine hesitancy in the United States, you don't understand where vaccine hesitancy is coming from, at least especially among Black and brown communities. The kind of collective resistance among white, middle class, and upper class women is a totally different story. But really thinking about why syndemics occur and what they are matters. So a really good example is we see this extraordinary syndemic in different communities in the United States. And a lot of that was driven by political leadership, poor political responses, which let coronavirus run wild and really cultivate and interact with these long-standing non-communicable conditions. On the other hand, in New Zealand, they also have inequity. It's a very different nation, but they don't have COVID-19 because they contained it. COVID-19 is not syndemic there. It's not global. And so it's really important to think about the political dimensions, the historical dimensions, the ecological dimensions that drive how conditions move, interact, and really cause suffering to people in some communities and not others. And that's why I think it's such an important tool for thinking about our global experience as humans, which are not all the same.
Got it. You mentioned a moment ago flourishing. I know you've explored a number of issues related to well-being, and your work in South Africa in particular addressed concerns about well-being. What have you learned in your experiences there that could help us understand better our responsibilities for one another?
Yeah, so I actually have a couple pieces coming out on Flourishing. I'm the new co-editor-in-chief of a new journal, Social Science and Medicine Mental Health. So if anyone has something, please reach out to me. But we are doing these new series. So I'm actually contributing to one. We're trying to set the stage of what do these series look like, and they're a kind of introductory piece and two comparative pieces. So one of the pieces is led by my RA, my research assistant, who's this fantastic woman, Lindy Leasile. She's worked with me for almost a year and a half. She just kind of moved on for a new teaching gig, but she led this paper, and it's basically writing about flourishing in Soweto, where we work, which is this multicultural, multi-ethnic community, multilingual community. But many people have been living in Soweto for now generations. And it is looking at how people define health on their own terms. So flourishing, as in contrast to resilience, which is doing well in spite of suffering, or suffering, which is not doing well, having this kind of expansive experience that's creating, such adversity. Flourishing is not necessarily about an instance in time or a measurement. It's about a pursuit. So I think it's really interesting to look at how people pursue and conceptualize a good life, a moral life, a successful life. So I've been really, really passionate about thinking about how people define what a moral life is, what a good life is, what health means, and what part of life it makes up. And so that's what I've been really focusing on flourishing. I think these pieces are just going to be wonderful, and my colleague did a great job of leading it. So I'm really excited to celebrate her in this work.
Before we close, tell me what it's been like with STIA during this period of virtual learning that we've been immersed in now for almost 12 months. We're in our 12th month of coping with a virtual learning environment. How have you adapted, and how is it going in our School of Foreign Service with our program in Science, Technology, and International Affairs?
I haven't, despite the Zoom fatigue, I found it to be quite delightful. I mean, we've had just experiencing different ways of learning and teaching and being and engaging has been very deep. I really miss the coffee chats. I love my STIA colleagues. And, if you're ever on the 5th floor in the STIA hub, we're always chatting, having a coffee. We're very collegial. So, and we have students, lined out our doors. It's the best thing is seeing our students. So that's what I miss the most. I'd often kind of stick around after class if I had someone covering my kids, and chat with my students, which was great. But it's not the same as you chat for 30 minutes. You got to build 30 minutes into every post-class period just to kind of follow up with students. So that was challenging. We were in person, but I actually think it has gone pretty well. But every class is different. So we have this gateway class, STIA 305. That's just fun. It's just fun. We have 4 different faculty who teach it, and we teach about different kind of science and technology and international affairs questions. So I always teach a global health unit, and that went well. But we had simulations that the students were like, it doesn't work as well when it's not in person. But we did a great job. We did our best, and we really adapted. Joanna Lewis, our director, has done a fantastic job of shepherding our program through. Really has stepped up. I think that class went okay. The simulations we're trying to rethink to make it more effective online. Those are, what the students like the most usually, and it was what they liked the least this last time. So, we're adapting because we're adaptive. I teach a class called Global Health Foundations it just went so well online, and it's super didactic. I kind of cold call students, so they have to really read and come prepared. So it was easy because I didn't forget anyone's name, and it was all up there, and it just was really easy to do that didactic teaching, and all the students were on their toes, and they just were amazing. It was a privilege to teach that. I just felt like it went so well. And, then my senior seminar, which is really based on our community and like the relationships we build. And, I always bring them treats. And that was harder because we couldn't build the community that we do in person. It went fine, but I felt there was a real loss of space and intimacy that we build together as a collective. Their senior year, and they're all thinking about the next move. And those moments together, after class, during break, were missed. So, everything's different. I think we all as faculty and students adapt. We all have our own issues. I had plenty of students who had COVID, had, family suffering they were caring for, different things that were even COVID related. So, really meeting students where they are is what we as faculty are trying to do to really care for cure personalities, really think about people as whole people, which you have to do during a pandemic. So it's exhausting, but there were also positive things that came out of this. So I think most of my colleagues would agree.
Thank you. Thank you. Thank you for all of your great work. As we close our conversation, is there a message that you'd like to share with the members of our community?
Get vaccinated.
Okay.
Please get vaccinated. I think this is, we are at this critical, I'm very busy, but I just volunteered to work at a vaccination center. So we all have to roll up our sleeves and do our part to really get back to our lives and really care for each other. So, it's been a privilege to share this moment with you. And, I wish everyone good health, much love, and safety in these next months.
Thank you. Thank you. Professor Emily Mendenhall, thank you so much for joining us for this conversation. We're grateful to you for your extraordinary service here in our community. And I look forward to being with all of you again soon. Take care of yourselves and take care of everyone around you. For every Hoya, everywhere.